Hello, this is Dr. Nettleman bringing you For Your Health again. We have a regular program here, and today I have the privilege of having Dr. Neil Ghushe, who is a general surgeon at Brigham and Women, and you spend some time at the South Shore Hospital now. And I had the opportunity of seeing a short presentation that you made to the doctors, and it had to do with bariatric surgery. And I think there's confusion with that term, and perhaps I'd like to introduce you. You can tell us a little bit about yourself and your practice, but more, what is bariatric surgery?
Sure, and thank you again for having me on the program. It's a great opportunity. Bariatric surgery has sort of turned from just being a weight loss surgery to really being a metabolic and a weight loss surgery. And I'll go into a little bit more detail about what that means. A little bit of background about myself. I grew up in northern New York, and I trained in Rochester, New York, where I went to med school as well. And I've been with Brigham and Women's and with South Shore Hospital for about 4 years now. My practice is primarily based in Weymouth. That's where our office is, and that's one of the focuses of this new weight loss surgery bariatric program, is to really introduce and bring some of the resources that we have in town down to the South Shore in terms of allowing the patients to have access to these weight loss services closer to the South Shore.
What is unique or what's different about this surgery? The surgery itself, I presume, is sort of routine, you might say, but it's the things leading up to and during and following. Could you elaborate on that a little bit for us?
Sure. So as we know, especially in medicine, but also in you watch the news, in society, obesity is a major health problem. And it's only getting worse. And if we go to the next slide here, this CDC slide that pops up every 10 years, which is based on the census, the red shows where there's really endemic problems with obesity. And as you can see in the South, but really throughout the country, there is significant problems with people being overweight and being obese. The map to the side there is just the issues with getting into Boston, and one of the reasons why our program down in Weymouth is trying to grow. But the obesity is the main driver for bariatric surgery. It really is the problem that we're trying to solve with surgery. So the surgery itself, is we tell our patients as they're coming through the program, is a tool. It's a very robust tool, but it's only one piece of the puzzle in terms of weight loss. And what we really try to focus on as patients are going through the preliminary steps and getting interested in the program is to know that it's only a tool, and there is no cure for obesity. That the surgery is a very robust tool, and it's the best tool that we have currently.
Now, these are people that have probably spent years with dieting, and a lot of times, well, you refer to the BMI. Could you explain to us what that is and what part that plays in qualifying a person for this surgery?
Absolutely. So if we go to the next slide here, this is sort of an old indication, but it's still the indications that we use and that the insurance company use in terms of people that qualify for surgery. And the BMI is a measurement, it's a calculation of your height in comparison to your weight. So for example, someone that's 5'7" and weighs over 250 pounds would qualify and be categorized as morbidly obese. That means a BMI greater than 40. So if we go to the next slide as well, the indications here that insurance companies use, there's a BMI greater than 35 at a minimum, and if it's greater than 35 and less than 40, then you have to have a medical condition that is associated with obesity. So specifically diabetes, blood pressure, sleep apnea, there are some other arthritis, joint pain. Those are the most common reasons that we would operate on them. And that's one of, again, the benefits of weight loss and with weight loss surgery, is that it's really not just about the weight loss. It's really about the other medical issues that get treated with weight loss. That's really in cancer, all these other things that have been associated with weight gain and with obesity have a meaningful impact by having weight loss.
So it would be helpful if a person who was overweight had some of these secondary diagnoses?
Only if they, right. So that's sort of where in the 2010s we've been sort of moving away from just talking about surgery for weight loss. And that's where this metabolic surgery piece comes in. So what we've found in doing these operations on people that are morbidly obese but also have diabetes, for example, is that it's not uncommon for someone to be on insulin, to be on multiple medications for diabetes, and having one of these surgical interventions done, that they're off of those medications. That they may, if they're taking insulin, they may be on a significantly lower dose of it. If they're on 3 medications for diabetes, they may be on none or just one. And that goes into this metabolic piece, so that it's not just the weight, but the way the body sees food, the way it responds to food, and the way the body adapts to that.
I think it's important for people to understand that at no time do you claim to cure the disease.
Right. And part of the screening process and part of the protocols and the procedures that patients go through to make sure that they're going to succeed with surgery is that they understand that it's not a cure. And so it's very important as they go through the program that they meet with our nutritionists, that they meet with our psychiatrists, to make sure that they get all of the tools necessary to have not only immediate weight loss, but to have weight loss that is sustained for a while after surgery.
Well, let's say there's someone who is interested in this type of surgery. What would be the normal steps? I mean, how they would make contact with your department first, and what's one of the first things that you would arrange or set up for these people?
So I actually have a slide on that as well. We can move to that. So really I guess I didn't have it on this one, sorry. This is really I guess the plug for the program. The new patient coordinator at the Brigham really sets up the core appointments. And what those core appointments are is once they make that phone call or go to the website, they can get all their appointments set up with the surgical consultation, the nutrition consultation, the psychologic or psychiatric consultation, and that's really the most important first steps. From there may be other testing that I order or that the psychiatrist or the nutritionist orders, and then it really, again, we want to be sure that people that are serious about surgery and serious about the weight loss are going to be able to handle the surgery and are going to be able to handle the recovery afterwards and the diet restrictions that may be associated with it.
Now, is there a particular age that you think is more favorable for outcomes?
So with our program, we typically don't operate on anyone less than 18 years old, and the upper end is a little bit more on a case-by-case basis. So 65, 70s, sort of, we have to know that medically they'd tolerate the surgery and that they would have some benefit with the surgery. But most of the patients that I tend to operate on are in their 20s, 30s, 40s, 50s.
How long has bariatric surgery been out there?
So and when we can talk about the surgical options that we have, but back before nowadays we do most of these surgeries laparoscopically, and what that means is through 5 to 6 very small incisions about that big throughout the belly, and we use a long camera and long instruments. Before that era, all these surgeries were done through an open incision on the belly. And so we're talking about 50, 60, 70, 80 years worth of experience in dealing with obesity and doing these operations. So we have quite a bit of experience in knowing what the complications are and also knowing what the success rates are.
It's my recollection that the first types of bariatric surgery were more the bypass surgery.
Correct. And so
which is the most severe, you might say, today? Right.
So the procedures that we really do now they're basically turned into, and this slide here kind of talks about the variation in them, kind of going from the simple, less effective type options, which is on the left, to the more complex, more risky potentially, but also more effective, and that's the gastric bypass on the right. So the three sort of operations that you see there on the left is a gastric band, and that is a plastic band that is actually wrapped around the top part of the stomach and then connected to a port that is implanted below the skin. And there's cushions that go around that band, and you can inflate or deflate the cushion depending on how tight you want that area to be. This was very popular probably about 10, 15 years ago and has sort of dropped in popularity more recently.
Why is that?
Well, as you can imagine, having a plastic band wrapped around anything for a long period of time can start to have issues. And we found that the weight loss people were having was not as robust and not as long term. So it's dropped in terms of the number of procedures we do of them. The next one on the slide there is what's called a sleeve gastrectomy, and that sort of replaced the band in terms of the risk profile. And what we do in that operation, the normal anatomy is you can sort of see there is the esophagus goes down into the stomach, and the stomach meets up with the intestine goes out throughout the abdomen, and then it meets up with your colon on the right side there. And I don't have you can compare it to the picture on the left, but basically we remove about 75 to 80% of your stomach so that you're left with a very long sleeve, and that's why it's called a sleeve gastrectomy. So the amount of food and drink you can put into your stomach at a given time has significantly dropped, which is one of the reasons why it works. But it also works because it's more than just the anatomy of it. There's hormones, there's other chemicals that the body senses in response to food and in response to hunger that also gets limited by removing that part of the stomach. And so that is why it also has some of those other effects in terms of diabetes and other medical issues.
So in this case, the stomach itself is made smaller.
Correct.
But everything beyond the stomach is left alone.
Correct. So some people talk about this as being more of an anatomic operation because we don't rearrange any of the intestine. We do a formal resection. We actually remove part of someone's stomach, so that is a permanent operation. So people have to understand that.
Might it, over years, adapt or accommodate larger amounts of food?
They can, and so typically we have a very graduated plan in terms of how people first drink just sips of liquids, and they move on to protein shakes, and they're really on that for a while until things have healed. Eventually, patients are able to eat a regular diet again, but it's about portion control and about making sure that they're sticking to their calorie restrictions so that they aren't gaining weight. But eventually, the stomach can adapt, and so what patients typically see after these operations is pretty rapid weight loss. So within the first few weeks to a few months, patients have lost 20, 30, 40, 50 pounds. That starts to plateau after the first year or so, and that is usually where people stay for the first year to about 5 years. There is a gradual weight regain that can happen after that 4 or 5 year period, and that's why the other tools are so important in terms of exercise and portion control to make sure that that doesn't happen.
Right. And the third procedure that you had up there.
Right. So the gastric bypass, as you mentioned before, is the operation that's shown on the right here, and that is I guess the gold standard, we'd call it. It's the one we've had the most experience with. And what we do in that operation is we actually limit the size of the stomach to just about 30 cc's, about an ounce. So very small gastric pouch is left. And then we actually divide the bowel lower down and reconnect the bowel to that pouch. So it works in 2 different ways. It's a much smaller pouch, so you can't, the same way the sleeve works, you can't drink or eat too much at one time. But then we've also bypassed a significant portion of the bowel where the absorption happens, where the nutrients are taken in by the body. So that's why we have the most success with it, because it works on those 2 different elements.
And today, with today's science, what percentage would you say you do of these procedures today?
So it's a pendulum, and the pendulum really has swung towards the sleeve, meaning that in my training, we probably did about 75% bypasses and 25-35% sleeve gastrectomies. And now that's probably switched the other way around, where I do probably 75-80% sleeve gastrectomies and 25-30% of the bypasses.
Why is that?
So what we found is the sleeve gastrectomy is a little bit of a newer operation in the sense that we don't have as much long-term data on it, and we're getting more and more of that. But it's really the risk profile. We're not reconnecting the bowel. We're not worried about leaks. The complications are a little bit less. And what we found is that the weight loss with the sleeve gastrectomy compared to the gastric bypass is pretty comparable. So that people aren't losing quite as much weight as they do with the bypass, but it's still more than enough for most patients in terms of getting the health benefits.
Historically speaking, the bypass was the first procedure that was done?
Correct. So there's the gastric bypass. There's a lot of almost legacy operations that we call them now, called the duodenal switch. The biliopancreatic diversion is the other one. And those, we really don't do them anymore because there was a lot of other risks associated with it. But all of these operations involved rearranging the bowel with the stomach so that you don't eat as much at one time and you don't absorb as much of the food.
Well, being very naive, why would historically they start with the most severe procedure?
Well, as with a lot of things in medicine, we just didn't know about them until we started doing them. And there was other procedures very similar to the sleeve that we did, where it was called a vertical gantted gastroplasty, where we stapled off the stomach, but we didn't actually physically remove it. And you'd think that that would have worked well, and that actually was a very common early procedure as well. But there was not as much good results with it. And so it's like, again, a lot of things in medicine, it was a lot of trial and error until we finally found the bypass and now the sleeve that were meaningful operations that had long-term good results.
So the more complicated, the greater the weight loss, but also the greater the risk of complications.
Correct.
So what is it that you anticipate for weight loss in these various procedures?
So when we talk about weight loss with morbid obesity, we compare it to what someone's ideal weight should be, so what their weight should be for a given height. And for a gastric bypass, we expect patients to lose about 60 to 70% of their excess weight. So they're not going to get down to their ideal weight. I mean, there are some patients that do, but really we're talking about, it's not about the weight loss, it's about getting to a healthy weight. And so that by losing that 60 to 70% of that excess weight, that's where they get there. So that's with the gastric bypass. With the sleeve, we expect 50 to 60%, and that's really where that difference is really not that different.
So the sleeve is about the same.
50 to 60 versus 60 to 70.
In the first procedure, the cup, what did you?
The band.
The banding.
So that's probably more like 30 to 40%.
Okay. How many people go through these various procedures and gain their weight back?
So the numbers, the data would say that about, so if you took 100 people that had either a gastric bypass or a sleeve, at 5 years, at 2 years, 95% of them, at 2 years, 95% of them have lost that 50 to 60% and kept it off. At 5 years, we're probably closer to that 40 to 50% mark, of that excess weight. But of those patients, again, 80 to 90% of them still have had meaningful weight loss at 5 years. And what I focus on, especially in those patients that do gain some weight back at that period, even if their weight has gone up a little bit, their other medical conditions often are still treated pretty adequately, meaning that if they had diabetes and that was successfully treated, often that still is fairly well treated, as well as high cholesterol, high blood pressure.
Right, the diabetes, I have a list here, diabetes, the high blood pressure, as you say, high cholesterol, sleep apnea, and of course, the gastroesophageal reflux. Mm-hmm. Yeah.
And I think the most profound thing, excuse me, that patients experience is a lot of these patients experience significant back pain, joint pain, and that's one of the earliest things that actually gets improved. And so the energy level that I see in my patients post-operatively that bounce back after surgery pretty quickly within 2 to 3 weeks, that's usually the most profound thing that they say is like, I can walk up a flight of stairs, I can jog, I can do all these things that I wasn't able to do for years. And that's the most rewarding thing as the surgeon, is that you really feel like you're doing a not only life-saving operation, but a real lifestyle-changing operation for these people. I was going to show a quick video of what we do in terms of the sleeve gastrectomy, especially since it's become so popular. And I'll preface it by saying that what you're looking at is we're already in the abdomen at this point, and we're staring at the liver, which is on the upper part of the screen. The gallbladder is to the left there, and right in the middle of the screen is actually the stomach. And we're looking at the lower part of the stomach in the video here, and we're grabbing the bottom part, and that's really where we start the procedure. What you're seeing here is a special surgical stapler, and what that is doing is dividing the stomach. We've put a special sizer down the esophagus, and that makes sure that we don't narrow the sleeve too much, but also make sure that it's small enough. So as you can see, there's little tiny clips, little staples. That's what seals the stomach on either side, and then it cuts in between. Going to the right side of the screen, that's going up towards the top part of the stomach. And again, the liver and the blood vessels coming from that area are seen to the left there. We use that surgical stapler to basically go all the way down from the bottom of the stomach, all the way up to the top of the stomach, where it meets up with the esophagus. And I can skip forward here a little bit. And you can see at the end here, this is what we're left with, is that those white strips are where the staples are, and the sleeve is what you're left with. So if you can remember what the image looked like at the very beginning versus what we have now, we've removed a significant portion of the stomach, leaving this sleeve behind. And that's what the patients leave the operating room with after we remove the stomach.
So you've basically reduced the size of the stomach.
Correct.
Very good. Thank you. And what else would you like to show us here?
Go back to this here. So that's really the only other thing I'll add is that, you know, if there was a better option, meaning if diet and exercise was successful, or if there was medication that was successful, or if there's some other less invasive, non-operative intervention, that's really what we're looking for, and that's where the future is in terms of metabolic surgery and weight loss surgery, is trying to find something without surgery. Surgery, we know what the results are with that. So some of the newer procedures that just this past year were approved by the FDA are endoscopic or less invasive operations where we're not cutting, we're not removing parts of the anatomy to have the same benefits. And I'll just mention a couple of them here on the picture. You can see the one on the left is what's called a balloon, a gastric balloon that's actually placed endoscopically. So that's with a camera that's placed down the mouth with just sedation as opposed to anesthesia. And that's a balloon that's filled with saline that actually takes up space in the stomach. And that's designed to basically take up space in the stomach so that people can't eat as much. And then on the right is what's called a vagal nerve stimulator. So that's actually some electrodes that are placed on the nerves by the esophagus near the stomach. And those are designed to help with some of the feelings of being hungry and some of the nerve impulses that control being hungry. So those are really the newest that we have. It's really hard to know where they will be in another 5-10 years. But again, we're looking, and research is going into what we can do next other than surgery.
And for years and years and years we've had diet pills, and now we have fewer than we did before. It just seems that people who are heavy like this just don't have that central nervous system control over being satisfied with what they have.
Yeah, and I think, you know, it's easy for me as a doctor and as a clinician to say to someone, you need to lose 10, 15 pounds. We know how difficult that can be for patients. Difficult. And that's one of the reasons why surgery has become as popular as it has, is because it's the only real tool that we have to help people with that. Obesity and weight gain is not just an overeating problem. It really is. There's lots of different factors that go into it. And so just saying, you know, exercise more, you know, eat less is easy for me to say, but it's very difficult for the patients to do. And so that's why we talk about surgery as such a powerful tool, because it helps on lots of different levels. There's the fact that you can't eat as much, but then there's also the hormonal parts of it that we talked about. And there's the psychology that goes into it too, to know that you shouldn't eat that much and you can't eat that much. It goes a long way in making sure patients stick to the diet.
Right. Now, are all the services that you mentioned with Brigham, are they available now at the South Shore Hospital?
Most of them. So what we do in the operation, what we do in Weymouth is basically everything but the surgery. So What we have in Weymouth is the first way that the patients, after they call that phone number, is they attend an information session. And that's where they get kind of the broad information about the whole program, how they go through it, all the steps of the surgery. And that's a session that we have at our office in Weymouth. And then from there, again, we have those core appointments with the surgeon, with the nutritionist, with the behavioral therapist, making sure that their insurance will approve it. And then after surgery, the follow-up visits, all of the lifelong care that they're going to need is done in Weymouth. Currently, we offer the surgery itself either at Brigham and Women's Hospital or Brigham and Women's Faulkner Hospital. And the surgery is usually, again, laparoscopic. It usually involves a 2-day or 2-night hospital stay afterwards, and then patients go home after that.
Okay, and you do your surgery at one of those 2 hospitals?
Correct.
Do you think it'll ever be done at the South Shore?
That's our grand plan. I do the vast majority of my other surgery at South Shore Hospital, and the plan is to have a fully integrated program at South Shore Hospital.
Is there anything else on here? We have 2 minutes left.
I think again, I'll leave it with this last slide here. If patients or people are interested in getting engaged with the program, really going to either the website, where a lot of these videos are as well, or calling the phone number for people that are interested or families that are interested, that's the first step, and they can give a lot of information.
Very good. Well, I'd like to thank you very much for joining us today, and I think it's been very interesting and very informative. Perhaps if you want to come back as a guest sometime.
Absolutely.
On another topic, we're open to suggestions. But I'd like to thank you again for appearing, Dr. Ghushe.
Thank you very much for having me.
And you can be reached at the phone number, I believe.
Correct.
Right. And that will be it for today. And this is Dr. Nettleman bringing you For Your Health. I hope you've enjoyed the program. Thank you.